Hello, I'm Holly Tanner with the Herman and Wallace Pelvic Rehab Institute, and I am interviewing faculty member Ramona Horton today about her myofascial course. Good morning, Ramona, and can you tell us a little bit about yourself and your background?
Thank you, Holly. So, my background is I was a physical therapist trained in the military and lived a few places all over the world. Spent about 5.5 years in the Army and then another 10-ish in active reserves, but pretty much have been ensconced in Southern Oregon now at the Asante Health System for the last 27 years. Never thought I'd stay at one place for that long, but found a home, found a niche here, and pretty happy with it.
hmm And what is your relationship to manual therapy work? What kind of coursework got you passionate about it?
Oh boy. So actually, we started with manual therapy in the military. I learned advanced manual therapy techniques, manipulations, spinal manipulations in school, and the part of the whole background of the military is always mission first, and so we it was learned this works. We don't know why it works, but it helps people tremendously. So manual therapy was incorporated from day one in my curriculum. But I know that a lot of people question manual therapy. And so the courses I teach are manual therapy based, the myofascial course. And we spend a fair amount of time in the pre recordings talking about what we really know about manual therapy. That, first of all, we're not putting anybody's anything back into place. Nobody's pelvis is up, down, in, out, right, or left. And we have good evidence that shows that it isn't. But what we also have pretty decent evidence that shows that asymmetry matters. And the tenets of the myofascial course are an osteopathic tenet called ARTS: asymmetry, restriction of mobility, tissue texture changes, and sensitivity. And the whole myofascial course is designed around looking for ARTS. And then when you find the asymmetry within the myofascial system, then that's where you direct your efforts and energies.
Yeah,
Go
that
ahead.
seems like a great foundational place to keep coming back to. And when you talk about that sensitivity, one of the things, you and I have both been at this for a bit of time in terms of taking coursework, having patients to work with and seeing what works. And I think you and I also tend to see patients who perhaps have some severity and some chronicity to their issues. And I often find that they've tried exercise, they've tried breathing and yoga and medications, etc. And it's the manual therapy piece that they often have not had. And is that your experience as well?
Exactly. It's not that uncommon for me to be somebody's second and third therapist. And some of them may have tried some kind of manual therapy, but it was more things like ischemic compression, where it was the problem was that the manual therapy was triggering nociception. And this idea that you just have to grit yourself through it, which just makes me crazy. So the myofascial course, we start with arts, but then we also have an idea where we flip arts on its head and we go to star. Again, they're just acronyms. And star, you take sensitivity and put it to the top of your list. That's your paradigm. That becomes the highest portion in your paradigm. And so then we use simple techniques that are non nociceptive, indirect techniques versus a direct technique. And something as simple as just positional inhibition. Um, and so the whole idea of the myofascial course is to teach people to think and problem solve, and then have a very broad spectrum way of you find an intra-articular issue where this joint's moving and this one's not. And we really want to learn to not chase the boo-boo. Just because it hurts on the right doesn't mean you're going to treat the right. It might hurt on the right because there's a hypomobility on the left. And so let's treat where the brain is protecting the tissue and holding and guarding the tissue, and trust in the belief that the body is a self-righting mechanism and that the body will then normalize itself. Because in manual therapy, our job is to try to get the body moving like it's supposed to.
Mhm.
And it's not to fix the boo-boo. It's not the issue's not in the tissue. If the tissue's tight, it's tight because the brain's keeping it that way.
Mhm.
And so, for the way I teach manual therapy, is that the fascial system gives us access to the nervous system. That our fascial mechanoreceptors are constantly in taking stock of our internal environment and our even our external environment, our exteroception. The visceral courses deal with interoception, what's happening on the inside of the body, where the myofascia is on our greatest amount of nociceptors are found in that superficial panicular layer of the fascia. And so by utilizing the fascial system in a non-nociceptive manner, what we're really doing is just having a conversation with the brain. We're not fixing the tissue. And that's the whole premise of the courses, and trying to get people to understand that and change their thinking and change their entire paradigm away from they hurt here, therefore the boo-boo is here, and asking what the brain's protecting, and then utilizing the fascial system with any number of layers of the fascial system to try to have that conversation with the brain.
In the pre-interview, you'd mentioned that younger therapists tend to have sometimes a negative bias towards manual therapy. And I think we can have a really fun conversation about explanatory mechanisms, right? Again, over time, you and I have probably had different things come out of our mouths when people say, "What are you doing? How is this working?" And I'm so much less attached to the how and the why, although I want to read every paper that all these brilliant scientists are doing on, the molecular activity in the fascia and all
Yeah.
those things. I want to know what they are learning and sharing. At the same time, I'm not that attached, and I'm willing to say to patients, well, we're not really sure, here are some theories, right?
Mhm.
And I think, do you find sometimes that newer clinicians can get hung up on the explanatory mechanisms, and when one is proven to not perhaps be the most reasonable, they want to throw out the techniques just
Oh,
based on that?
oh, I agree so much. And again, a good example. What we used to use is positional diagnoses for the pelvis. Okay, well, their pelvis is right rotated. Well, the research has shown us that that's just not accurate. We can't say that, or that the right hemipelvis is anterior or posterior or up slip or down slip. The research has shown us that those diagnoses just aren't accurate. But I've treated hundreds of them, and I know I make people better. So I am completely willing to throw out the explanation. And I personally am completely willing to retrofit a better explanation to a technique that I know perfectly well is effective. And that's what I want to do, is try to teach people, here's what we know. We know for a fact that we stimulate mechanoreceptors. With nociceptors, proprioceptors, we know we're doing that. We know that those are going up to the brain, and that a change is occurring, and the change is occurring through, we know that we get modulation of the periaqueductal gray area. We know that we get the pseudopodia that are found in the fascia, in the myofibroblast of the fascia, that they reach out, and that the fibroblast distorts itself. That within the collagen fibers of the fibroblast, we have smooth muscle active, and that contracts and changes. And we know that we release endogenous cannabinoids in response to manual therapy. So we know that certain physiologic and non-physiologic effects happen, or I should say physical and physiologic effects happen. But we can't say this always is direct cause and effect. So my answer is that we're having a conversation with the nervous system, and the brain is making a change,
Hmm.
the patient's brain.
Yeah.
And
Right, which has so many factors. And of course, the class itself focuses on the manual therapy techniques. It doesn't mean you only do manual therapy in your practice.
right.
You're always bringing in all those other pieces.
Right. Yeah. Years ago, I wrote a piece about sort of my whole philosophy, and I start with a triangle. It's Penrose triangle, and it's an optical illusion with this ball moving around the triangle, where it's showing this as a continuous loop. And in the picture, I have the brain in the middle. And what I advocate that we do is we find all the places where the brain is, where the body's struggling. We find the barriers that they're dealing with. And then we take those barriers and we divide them into either psychosocial, because we have to address those pain misconceptions. We have to address their catastrophization. That's essential. We look at all that. And then we look at the somatic system that we would address with manual therapy. And then we have to look at their movement impairments. So we need to train movement with anything that's going on within their musculoskeletal system, well, within their neuromotor control system. And that doesn't necessarily mean strengthening, it might be timing and coordination. So I advocate that we look at it, we break down wherever their barrier is into one of these three categories, and then utilize the techniques that you know in each of the categories. And I'm going to teach you this weekend some techniques to use for the somatic system, for where utilizing manual therapy.
Hmm. And what kind of feedback do you get from participants about this particular course?
We get really great feedback because the course teaches, again, it's a concepts course. I'm not going to teach you 87 techniques. I'm going to teach you how to think. I'm going to give you representative techniques that I use very, very frequently. But I'm going to ask you to say, okay, does this look like it's a issue at the panicular layer of the fascia? Is this an issue at the axial layer of the fascia? Is this an issue at the neural layer of the fascia, the dura? Or is this an issue at the visceral layer of the fascia? And is it an articular problem? Is it an intraosseous problem? Is it so? Learning how to find what kind of a technique you would use is based on the anatomy that the brain is protecting. So, so you don't have to take um, a 3-day hip course on mobilization of hip structures, where we just basically said this is an articular technique. You can use it on hip and elbow or knee. Teaching representative samples that I use a lot.
Hmm. And do you find that the visceral courses also pair nicely with this work in terms of just some of the framework and structure that you approach this manual therapy with?
They do. The basic framework is very similar with all the courses. The idea is the fascial system has 4 layers: the panicular, the axial, that visceral, and dural. And so just depending on where the body's struggling is depending on the layer that you're going to be approaching. But the truth is, ultimately, the only thing we really do touch is skin. So we have to recognize in manual therapy that we sort of coming full circle to what you started with, that we need to be really careful of the explanations we're using. And we have to recognize we're working with the nervous system in any and all of these techniques. We're working with the nervous system, and that ultimately the skin and the nociceptors in the skin and all of the proprioceptors in the skin are really what we know we're stimulating for effect. And we're trying to get down to these deeper levels, and we do some drills on palpation to help people learn to recognize deeper levels. We do drills on depth of intention, and we have some fun ways to help people learn to recognize and say, yeah, that was deeper. Yeah, that's more superficial. I can see how I can feel the difference between those, and try as much as possible to train their kinesthetic skills.
Hmm.
So when they walk away, that they can feel confident. But the courses all do blend together. In fact, the work in the myofascial course was in the original 2 visceral courses, and it became apparent that it was too much, and so they got pulled out, and then was able to expand on the myofascial course. And the latest thing I've added to it is a really comprehensive explanation of augmented or fascial mobilization techniques for the panniculus using cupping and gua sha tools. And they
Hmm.
actually, the science and evidence behind those techniques, why we think they work, what we know we're doing, what we know we're not doing.
Hmm. Well, you continuously learn. Do you find that
Always.
you're just you don't run out of passion for the field and for learning itself?
I haven't yet. I have an insatiable curiosity. Anybody that spends about 30 minutes around me will come to the quick realization that I have a blessing of and a curse of ADD. I have attention deficit disorder. It has been a lifelong challenge. Anybody that sends me an email and expects a response will tell you all about that. Um, but because of that, I just have an insatiable curiosity about how things work. I need to be able to look inside, take them apart, put them back together, and understand. And being able, I joke about I'm a good instructor because I was a terrible student. Out of the 16 in my class in PT school, I am quite sure I graduated 16th. I didn't I don't take tests well. I don't learn easily. I learn by doing.
Hmm.
And so I try to create a whole program to help people learn by doing and explaining and experiencing over just reading and hearing.
Hmm. Well, the participants benefit from all the ways that you've learned to share your information with them. So thank you so much, Ramona.
Well, thank you for this interview, Holly, and I look forward to seeing everybody in the future.